Right, ladies and gentlemen, it's 3:30, so we're going to start precisely on time. And can I just say a warm thank you to everyone who came into our eyesight, because as you appreciate, once the lights go up, we can only see several rows out. So it's nice to know we're talking to people and not just an empty, massive space. So, my name is Nigel Crisp, and it's my privilege and pleasure to chair this session on a really important topic, the global elimination and eradication of disease. And what it's going to be is a mixture of some film clips from Al Jazeera, which we'll say a little bit more about in a moment, what this film is about. And then we are going to, in between these clips, I've got 4 people with me, and we're going to be discussing both the process of elimination and eradication, what you actually do to get rid of diseases. Some of these, particularly the nasty, neglected tropical diseases, is what our main focus is going to be. But also what the implications and what the learning are for other areas of healthcare and health. So that's the format. I'm joined, as I say, by 4 extremely distinguished people coming from different angles. I'm going to introduce our filmmaker first of all. On my right here is Ingrid Falk, who is the executive producer of programs for Al Jazeera English. She is a multi-award winning film producer with more than 25 years experience. And a bit later on, she's going to be telling us about a film that's going to be shown tomorrow, but this is also one of her films today, both of them about health in Africa. To her right is, I guess I'm going to call you our expert, Simon. Expert is Simon is the Director of Neglected Tropical Diseases for Sightsavers. So he's dealing mainly with the blinding neglected tropical diseases. But I have to say that of all the panel members, he's the only one who's actually had Guinea worm, which is the topic that the film is going to be about. So he's speaking as an expert patient, as well indeed as an expert panelist. Immediately to my left is Nneka Mobitson-Etuk. She is IHI's lead for Africa. She's the executive director for the African region, and IHI, as you may know, is working in 11 African countries. And then to her left, we have the WHO, the World Health Organization, represented by Ed Kelley. He's the director of service delivery and safety, and he obviously brings a lot of experience around the world, including time in West Africa. And I think something you're going to tell us a bit about is adapting some of the lessons from the elimination of polio to health more generally and to safety more generally. So we've got a super range of people with us, and we're going to kick off by asking Nneka to just give us 2 or 3 slides just to set the scene about what we mean by elimination, what we mean by eradication, but also to give us a little bit more insight into Guinea worm. So if we could have the slides, please.
Thanks so much, Nigel. We just wanted to highlight really the differences between elimination and eradication, and there's also control, which we won't really focus on today. Regarding elimination, it's specifically focusing on the reduction of the incidence and prevalence of a disease in a defined area to 0. So in order to ensure that there's no reestablishment of transmission of the disease or infection, one has to ensure that continuous measures are implemented. And then eradication is vastly different in that that's the permanent reduction of the global incidence and prevalence of a disease to 0. And in this case, intervention measures are no longer required. Now, you can see there essentially kind of the highlight. We're highlighting smallpox because globally, smallpox is the only disease that has actually been eradicated. The last case of smallpox was actually in Somalia in 1977. And here's where you kind of see these specific achievements in terms of global disease elimination and eradication. We've highlighted smallpox. Also, polio now is essentially endemic in 3 specific countries, Afghanistan, Pakistan, and Nigeria. But we have made massive improvements despite the need for continued efforts to actually eradicate these diseases. And lastly, Guinea worm, which we're going to talk about in depth today. We've made significant improvements in that, and they're currently, as of 2013, a little bit over 540 cases in 4 countries specifically. Lastly, before we enter into our discussion and view the video clips, we just wanted to walk through the life cycle of the Guinea worm with you. So essentially, how does it start? A human being essentially might ingest contaminated drinking water from a variety of sources. And in that contaminated water exists copepods, essentially small crustaceans that contain third-stage larvae. So once those are ingested, those larvae essentially infect the abdominal cavity and also enter into the intestinal walls. And after about, they mature, they reproduce, and the male larvae die while the female larvae exist and continue on for about a year until they essentially get to the skin and erupts, causes a small blister, at which point more larvae erupt from the blister and can enter into water. Now, typically, there's local pain or inflammation at the site, and so in an effort to actually relieve the pain, typically many people might enter into the water, what type of water source, to essentially help prevent kind of the pain that they're having. And at that point, larvae are released and the cycle continues. And so now we'll talk in depth more about guinea worm and eradication efforts, elimination efforts across the world.
Thank you very much indeed, Neka, for that introduction. So what we'll do now is we'll take the first clip, if we may, from the film, which, as you see, will focus on guinea worm. And can I just say, for the squeamish, there's a bit here where you might, in other circumstances, hold on to mummy or hide behind the sofa, or something of that sort, but when the guinea worm is removed. But anyway, let's have the clip if we can, please.
There are those who dream of possibilities, of a world free of the ancient diseases that keep billions in poverty. And for those who strive to make that dream a reality, their quest is on the brink of victory.
I take the Guinea personally because I think we are very close. We have come down from many, many cases to just very few. The other thing that I take also personally is that there are people who continue to suffer. For the individual who is suffering, it's a tragedy. For the family, it's a real problem. To me, it is a matter of life and death.
Mama down.
In ancient texts, it is known as the little dragon. Guinea worm has tortured millions with its crippling pain since human history began. There is no vaccine and no cure, but by 2013, thanks to a massive international intervention, there were only 126 cases left in the world, a dramatic reduction of 99.9%. Guinea worm is on a final, though difficult, countdown to zero. Today, all but a few of the remaining cases are found in a very remote region of South Sudan.
This was a terrible vacuum in the health care for literally hundreds of millions of people. So we decided that we would take it on as a project, not knowing the extent of it, not knowing where it was, not knowing really at that time how to address the problem.
When his philanthropic organization set out to measure the extent of the disease, it found 3.5 million cases occurring every year amongst the world's most remote and neglected people. Guinea worm was found in Pakistan, India, and Yemen, but it was in a belt across sub-Saharan Africa that it had the gravest impact.
Well, that gives you just a brief introduction, and I should say that President Carter, whom you saw there, and the Carter Foundation has been one of the organisations absolutely at the forefront of the elimination of guinea worm. But let's start off by going to the World Health Organization. So what is the World Health Organization doing about ensuring that we eliminate some of these, particularly these neglected tropical diseases?
Well, Nigel, the first thing to say is that the organization has been looking at this obviously for a long time. It's back in like the 1980-81 that the International Steering Committee on Drinking Water was starting to look at issues around guinea worm. But it was really when the organization started working more closely with the Carter Center in about '86 that progress really started being made. And I think the guinea worm example, we'll talk more about this, underscores the possibilities and the need for leadership by big international bureaucracies like WHO, but how it really needs the energy of private NGOs, private organizations, putting the spotlight on it like Al Jazeera. But you can see the former President Carter talked about it in the clip there, the progress that's been made. If you look at 2011, over 1,000 cases. Last year, NECA highlighted 546. Now, from January to November of 2013, there was 146 cases. So analysis is still pending, but I think it underscores the role for WHO on collecting data, certifying data, talking about the certification program. That's an extremely important issue for ministers in terms of leadership, whether they can get to that certification point. But obviously, that's not enough. There's lots of other space for other actors.
So one of the things you're saying is that actually it's the great international organisations, the NGOs, and as we'll hear later, it's also what happens very locally in villages. It's the entire spectrum, isn't it? Simon, I introduced you as the expert because your actual title is Director of Neglected Tropical Diseases for Sightsavers, and I better declare an interest. I chair Sightsavers as a non-executive chair of the trustees, and Simon is the person who does the work on this. So Simon, would you give us just a bit more introduction to neglected tropical diseases, what they are, what the range are, and where we are with them?
I think perhaps a better term for this group of about 17 diseases is really diseases of neglected people.
Yeah.
They impact on 1.4 billion people globally. If you group this fairly diverse number of diseases together, that burden of disease and that burden of potential disability is actually enormous. If you look at river blindness, called onchocerciasis, or trachoma, they blind. Lymphatic filariasis is one of the most disabling diseases in the world and is responsible for one of the largest group of people who are disabled, crossing continents from India into Africa. On the whole, they're a group of infectious diseases, bacterial diseases, and they have great stigma amongst the populations that they affect. And it's very difficult. You talk about 1.4 billion people being affected by these diseases, but they are diseases of communities. You can go into a community and visit a school, and you will quickly realize that most of that school population has bilharzia. It's seen as abnormal if the child does not have it, that they do not have the bloody urine that is an example of that disease. You can go into villages in Mali or South Sudan where a large proportion of the population are blind, and they are blind either because of trachoma or river blindness or both. And it becomes they are diseases of communities and those who are neglected. And perhaps they're an indicator of poverty, and they're also an indicator, a very clear indicator of poor access to hygiene, water, and sanitation.
Thank you for that, Simon. And one of the reasons we know we can eliminate and eradicate them, of course, some of these diseases were in England and France, weren't they? Only sort of 300 years ago, these blinding diseases. And we have moved on.
You're quite right. And Moorfields Hospital, for instance, in London, the premier eye health institution in the UK, was set up as a hospital for trachoma. And the only reason for trachoma falling in the UK and Europe was access to hygiene, water and sanitation, the introduction of that. And you can see that in other countries globally where economic indicators have increased. The disease does tend to fall off, like Oman, Saudi Arabia, United Arab Emirates, example, which were endemic for the blinding disease trachoma.
Thank you for that, Simon. Ingrid, I'm going to ask you the obvious question, really, which is, so why did Al Jazeera make this film?
Well, you're all experts in the medical, the disease, and in fact the context, which is very largely poverty and underdevelopment. What we do at Al Jazeera, which is a global network, so we're reaching to about 270 million homes around the world, is we believe that everybody has a right to have their story heard, and particularly those that very rarely get heard. Obviously, half of what we do is news, and we report a lot of really awful things going on in the world. And even within news, there's always a search for some sort of more solutions-oriented rather than problem-oriented stories. But the truth is the world is there's a lot of awful things going on. But in our documentaries and in our analytical and current affairs shows, we have a chance to spend time with the people who very rarely have either their voices heard or their stories told. And health is an issue that we're very, very committed to across the channel. We have a very nice other show called The Cure that looks at solutions only. We do a lot of health-oriented things. But these are particularly stories that take us to places that have been, if they are, neglected, for some people they're forgotten or unheard of. And even when I'm not an expert at all, this was a fantastic, I'm looking at this every time I'm learning more and more about eradication, elimination. What I'm about is storytelling, and particularly giving people a chance to show their own stories. So McCoy Ibi, who works in the South Sudan Health Ministry, you watch this film. I know it's awful and it has a health warning, but you watch it and you fall in love with this man because he is so passionate, and he's going out and he's looking for tiny little clues in tiny little hoof prints, indentations where there could possibly be infection. And these stories, if they unroll, these are 1-hour films, which is a lot of time to spend on a pretty grim disease. But you see the people working with the NGOs, with the local people on the ground, and it's actually a story that inspires an enormous amount of positivity. So you go from feeling, how outrageous is it that these diseases still persist, to feeling, oh my goodness, people are taking agency, they're doing something. And hopefully there's a sense that our viewers can feel inspired or impassioned or informed to move on with them.
Yeah, no, there was a very great line in that, wasn't his first line, which was, it's personal. It's personal.
Absolutely.
Between him and the worm, as it were. Yeah. Let's turn to Neka then. And Neka, people in these communities, of course, don't just have these diseases, they have other problems. Can you talk a little bit about that and maybe about how the two things fit together or need to be tackled?
The reality is these communities are suffering from multiple problems. They're suffering from, obviously, other tropical diseases, the burden of poverty, which expands way beyond healthcare. And I think the highlights, if you really look at where we've had success, whether it's in addressing issues around maternal and child health or other specific diseases, the real reasons are because we've engaged communities. We've looked at communities and essentially leveraged them to develop some of the solutions, to work together with us, hand in hand with global partners, with governments at the top, to really identify what the innovative solutions are in terms of focusing on the family and bringing the family in terms of defining how to make the difference, whether it's looking at water sources and figuring out how to ensure there's clean water and sanitation, in terms of educating mothers, children, fathers, and beyond, in terms of essentially figuring out at the facility level as well how to make a difference. And so it really highlights the need for communities as well to leverage those structures to address global problems and not just focus on one, but have a systems-based approach to ensure that you're tackling all the issues that they're essentially dealing with.
Thank you for that. So that's the sort of big introduction, again, of this context. Let's get into a little bit more detail, I think, in the next film clip. So if we can have the next film clip, please, we can look a bit at how this is being tackled.
Because guinea worm is waterborne, having safe drinking water is essential to eradicating it.
The process of getting water through drilling of boreholes is a long process. It is possible, but it is a long process, the most difficult. But we can do something much easier, and we can protect ourselves from guinea worm.
And the first step to providing protection is to let people see for themselves what swims in the water they drink.
These are numerous, and they have the typical jerky movement. Does it see those things? Okay, now tell her. Because she's refusing to drink this water because of those water fleas. So tell her that if people don't filter the water and then they actually drink the whole thing. You see this water? So who wants to drink this one? So why are they refusing?
They're all refusing just because they have seen these live things, and so it is what is bringing them to get guinea.
So that is exactly what they would drink if they don't use filter.
A reed with a membrane stretched across one end was the inspiration for the pipe filter, an idea that came from the Tuareg nomads of North Africa who had been using it for years.
And the Norwegian government made us 9 million of these pipe filters. We sent the pipe filters into South Sudan.
Pipe filters were ideal for nomadic people, but longer-lasting cloth was needed for filling buckets and jerry cans. President Carter approached a manufacturer of parachutes for money. What he got was more than what he had bargained for.
They gave us 6 million square meters of very fine filter cloth, and that was the basis on which we went into the villages and taught them what caused the disease and told them if they would strain every drink of water through that filter cloth that they could get rid of guinea worm.
Filtering drinking water to remove guinea worm-carrying water fleas became a mainstay of the eradication program. Over 3 decades, guinea worm was eliminated village by village and country by country. Nigeria and Ghana, which had recorded the highest number of cases in the world, completed elimination by 2011.
This is where it's going to end. This is the place right here where it's going to end. These are the people who are going to solve this problem once and for all, just like the Nigerians solved it in Nigeria and the Ghanaians solved it in Ghana. And it takes the people in the community to do it. And to see how we have a community of people coming together to interrupt a parasite life cycle and solve it without vaccines, without drugs, is just fascinating and really uplifting to see humanity be able to accomplish this across such a huge geography and a huge cultural diversity.
Great. Well, that started to get us into what you actually do. So Simon, I think I will turn to you first, if I may, and ask you just to say a little bit about not just for guinea worm, but what are the sort of typical stages you'd do in a program to eliminate?
I think the guinea worm program does give a very good example of what needs to be done. First of all, we need to map the disease that we're talking about. It might seem pretty basic that we don't know where some of these diseases are. If we don't know where those diseases are, then we can't, as an international community, apply for the drugs. Now, I say apply for the drugs and not purchase the drugs, because the drugs for 5 of the key neglected tropical diseases, those that have the biggest burden globally, are donated. Just because they're donated doesn't mean to say they don't have a value. One treatment for river blindness costs the company that donate it, who is Merck, $1.50. One treatment for trachoma, which is donated by Pfizer, costs about $20. So there's a cost to donated drugs. So we can't just go and treat a whole country without knowing where the disease is. Then we need to set up structures that get that donated drug to the communities that need them. The donations are fantastic. The donation arrives at the port. If the country does not have the structures, the supply chain mechanism that can actually get those drugs to the communities, like the communities in South Sudan that we've seen on the video, then that donation is absolutely pointless. You then need to engage with the communities, work with the communities. The communities want to rid those disease perhaps more than anyone else. They know the impact of these diseases on themselves and their children. They've seen this for millennia in all cases. And so working with that community to share with that community how this drug that has been donated will eliminate the transmission of perhaps river blindness or solve the problem of schistosomiasis among school children. And part of that is behaviour change and communication, making sure that information is understood, and making sure that the community members themselves are in charge of that whole process. And with river blindness, for example, in Africa, there are 1 million community health volunteers. And these health volunteers are responsible for collecting the drug from the health facility, undertaking the distribution of that drug amongst their own community, recording that distribution, having it monitored and checked. And in that way, we can ensure that we have high coverage of the disease. Because unfortunately, it's not just a one-off. This has to go on for years and years and years before you reach the stage of elimination. So if you don't engage with that community, it's to your peril. You have to work with that community and put that community in the lead, asking them how do they want this drug distributed. Do they want their volunteer to go house to house? Or do they want it done at a central point around an important festival? The community will make the right decision. They know when to get that very high coverage.
Simon, thank you very much for that. I mean, that ties in very closely with the film. And it also makes the point, doesn't it? There's been an awful lot of research gone into this, that actually that's not an accidental process. You need to know exactly how to fit all those parts together.
Yes. Yeah. Absolutely. We're not dealing with a sort of a pilot program. Yeah. We know it works. With river blindness, over about 100 million treatments a year are delivered through this community-directed approach. That's been going on for that's 12 to 16 years, and perhaps now the science is actually catching up, because it's now told us that if we distribute and have very high coverage for 12 to 16 years, you do break the transmission of the disease, and that's happened in some communities.
Because you're breaking the life cycle.
Absolutely.
Yeah. Let's turn to WHO. And one of the things when I introduced you, I said that you were very interested in looking at what we'd learnt from polio and from tackling polio. So perhaps you could say a little bit about that, if you would, Ed.
Thanks, Nigel. And I think the point made on mapping and data is probably one of the key lessons from a whole range of eradication efforts. And Nick rightly made the distinction between elimination, containment, and eradication. And this idea of, over time, understanding your enemy is at the core of any eradication effort, I think. And the mapping piece has been one of the most difficult parts for the guinea worm work, but it's also been at the core of work on polio. Now, polio is quite a bit different, and we saw in the clip there's a vaccine for it, so the mechanism for the eradication is, in some ways, it has a little bit less to do with the communities, or it has different aspects to do with the communities. It's not primarily about the communities taking control of this, because there is a vaccination team that comes and has to administer the vaccine. But like if you look at India, which was just recently certified as polio-free, was a huge success. I mean, it was based really on a few things. One, on this emphasis on data and mapping. The team at the WHO, for instance, on the polio team, can tell you which sewer the strain, the stool sample came from, then the strain came from, whether it be in Pakistan or another country. And the other aspect is really the people that are involved with eradication. The people involved with eradication, they're different than other people. It's like the theme, for instance, on polio is No Child Left Behind. It's the every last child. So they're constantly thinking, what have I left out? What have I missed? How did I miss it? How can I not miss it the next time? And so I think that learning aspect is there. Then you do need people. And with polio, you needed a lot of people. In India, they had 850,000 ASHAs, who were community health workers, paid very nominally, who went around and helped do surveys for flaccid paralysis, verifying the disease, and then looking at how it could be scaled up. But in the end, there's a lot of money that's been poured into polio, and there's a lot of discussion, which maybe this group should talk about, and others should talk about too, about that cost curve that goes up as you get to a certain level.
As you're trying to get rid of the last few cases.
As you try to get rid of those last few, and maintaining the political commitment. I think, again, there's lots of things WHO doesn't do well. Maintaining political commitment is one thing it does do well, and making sure that ministers and donors stay on it. So I think that's where the partnership works well. It's hard to maintain that as the cost curve goes up.
Yeah. Thank you very much for that. So you've exampled polio and river blindness and guinea worm. Slightly different approaches, but the same general principles. 850,000, did you say, ASHAs in India, 1 million community distributors, and I don't know what the figures would be for guinea worm in terms of the number of people who are handling the 6 million square feet of parachutes silk that we've just heard about. Let's go wider and see what else we've learned. I mean, so neglected tropical disease isn't your area of focus, Becca. You're thinking much more widely about healthcare. So what do you learn from this for other things you're doing?
Yeah, I mean, I even though NCDs are not our focus, the reality is it's a system-based approach. I mean, if you're really going to make drastic improvements, you have to have a system-based approach. And we've heard that both from Ed and Simon today. And I think we've tried to map out what the critical drivers of success are. Yeah. And we've heard it just now. Essentially, it's activated leadership. And leadership from the top at the Ministry of Health level, ensuring you're maintaining a shared sense of urgency. Activating it, but you're maintaining it as well until you've essentially achieved the solutions. But also that you're having kind of private sector partnerships that are supporting the Ministry of Health. Then secondly, it's access. So whether it's access to drugs, it's access to vaccines, how do you ensure there's a reliable supply chain mechanism to support this distribution? And there are financing mechanisms to ensure there's access to all for whatever types of commodities there are. And then data. So we've heard about data, and what does that mean? We always hear about data for decision making. How do you ensure that communities understand what the data is and they're actually able to act on it? And it goes all the way from community health worker or whatever community structures you're using, which may expand beyond community health worker all the way up as well. Lastly, we've also identified that you have to reliably implement a set of interventions. So the role of research, which we've heard about, that's clear. There's evidence that's out there. But that doesn't equal into appropriate implementation. So how do you essentially ensure there's continuously reliable implementation of those interventions? And one last piece was on education. So ensuring that community all the way up, there's knowledge, there's knowledgeable mothers, fathers, etc., but there's also knowledgeable health workers and a knowledgeable Ministry of Health and beyond.
Yeah. Ingrid, the point that Ed made in that was actually how do you maintain political will? How do you keep the momentum and so on? And I wonder if that's something that you as a filmmaker knows something.
Well, what is interesting for us is that we're probably the broadest of this discussion. And the critical thing is that as a channel and as a news and current affairs channel, we have to be absolutely independent. So these films were made with a lot of cooperation and finding out and research, but absolutely not one iota of editorial influence from NGOs, from partners, whatever. We have to be independent. Trust is our, the most important thing for us. So the other thing is how do you tell such a big and very complex story? I mean, these three answers have just shown this is really complicated. And the way we do it is to say, well, we're not going to give you too much hard information, not too much technical information. We're giving you experiential information. So we go on a narrative journey through characters and we develop it and we see the science gets drip-fed in various degrees and quite an interesting range of projects. And whether or not this will change the world, I don't know. We don't know whether documentaries change the world, but we have quite a lot of evidence to show that it shifts perspectives. Our job is not to change the world. Our job is to reflect the world and to point people towards the organizations that are doing things. And I'll talk about that in the next session. But what has been interesting for me as a non-expert is to see, so our leprosy film, for instance, in India, is looking at a disease that was eliminated and looking at it post-elimination, and you realize actually it's just the beginning of the end. It's actually still going on. And similarly, we chose polio in Pakistan because and the experience there is going out with the vaccinators and looking at the political will. There's a lot of political will, and then there's a lot of political antagonism. So the context is very, very complicated. And so we always go back to the personal stories and the people who are doing something. So much television is about victims, and we're looking at people who are in some of the worst and most difficult situations who have a sense of agency. And whether it's river blindness, trachoma, rabies, it's horrendous, and it can be, something can be done. So that's the nature of this series in a sort of editorially independent way.
Thank you for that, Ingrid. And a perfect lead-in, of course, to our last excerpt, which is about the community, isn't it?
Oh, that's...
Yeah. So could we have the last excerpt of the film, please?
All you have to do is change human behavior. Now, that doesn't make it easy, but it makes it definable. And then it's just a matter of creating the will and finding the right culturally sensitive ways to encourage people to change behavior about filtering water, about what to do if you have the symptoms, for example, not go into the water, and to bring a lot of peer pressure really to bear. Because as we know, peer pressure can be a powerful thing. And using peer pressure is really community pressure.
Well, let's continue with you then, Ingrid, on that basis.
All you have to do is change human behavior. I love it. That is going to be the best.
A simple matter, yeah.
Simple, just
from a parasitologist.
Well, and that scene obviously is people doing the work that you guys know so well in the ground, which is all about community engagement. So we're doing a very different kind of community engagement because our community is the world, and they are not necessarily people who are, suffering from these diseases. So apart from making a television series, which is 8 programs looking at 8 of these diseases, and the 8th film is actually about maternal and neonatal mortality, which is not a disease, but it's a big issue all around poverty and impoverished communities. So apart from the films, which hopefully you'll all watch, we decided to build a community of interest around this through digital and social media. And so we started about 6. The films only start airing on television tomorrow night, and we started 8 months ago building a community. We mapped all the organizations like yourselves who are involved in these issues, and we did the equivalent of pamphleteering. We kind of wrote or telephoned or made contact, and we put out tiny little web videos and little infographics, and we built up. And so we have already 10,000 people on Facebook who before we've even been on air, and we hope that the minute it goes on air it'll amplify out to much bigger communities. But we wanted to give people a place where they can exchange ideas and thoughts and get information. Again, we can't tell them to, march on the WHO or governments or whatever. That's not our role, but it is a place to find out more, and that's what we've been doing through the social media and through our more interactive website, and that will continue for 8 months after the films air, and that's quite an interesting project for us, all about engaging the people who watch our television and getting them to feel as passionately about these things as we do.
Thank you. What I'm going to do is ask Necker to say a little bit more about community engagement, but the face-to-face sort, and then actually turn to both Ed and Simon and say, are we going fast enough? This is fundamentally important, and is there enough effort going into it? So Necker, on the face-to-face, the person-to-person, the bit we saw in the film, as it were.
Yeah. No, I think, increasingly, I think over the last couple of decades, there's been a huge focus on community engagement. And so much so that, we've seen a lot of success and solutions with really focusing on community health workers. Because a lot of times they are based in the villages and they really know the communities best. Now, we're now facing a problem because essentially we're all coming to them and we're all leveraging them, to focus on this disease or this particular issue, and they're getting overburdened. And so a lot of the work that we're now trying to do is to figure out how can we use other existing community structures or support the expansion of others. In Malawi, we're working through task forces, and in Ghana and in South Africa, we're working through other means to look at specific community structures that may exist, that are comprised of village chiefs, village leaders, patients, so that the voice is always represented there, transport, drivers, community, other folks that are critical to the community and seen as having a voice, and really capitalizing on that to essentially have them essentially support the work, support whatever is needed, and help also drive the solutions. That's really been critical to the successes we've seen in respective countries in Africa, particularly around maternal and child health.
It's a very important point, this, isn't it? Not overloading the community and every disease and every organisation having links into a community. And I know that that's something we've done a lot of in Sightsavers, Simon, isn't it? Of delivering drugs for other diseases as well as the eye diseases.
Yes.
People have tried to link on that.
I think that should be how we as an international community are working. If you look at the treatment for river blindness, it's treated by donated drug Mectizan. If you add on one other drug, albendazole, then you also treat lymphatic filariasis. So you're treating 2 diseases for, in fact, the same cost, because the element of training of the health worker is not that much more for this other disease. So I think doing that is absolutely important, and also integrating and coordinating with other activities. Lymphatic filariasis is transmitted by mosquito. There are big bed net programs in Africa. If the 2 programs can work together, then you actually will impact on malaria and also eliminate the transmission of lymphatic filariasis, which in the end will save the health service in that country both time and money, the money to actually distribute the drug. I often see, the drug distribution is almost showing a failure of the health system to implement programs effectively. It's showing a failure to get clean water, sanitation to communities, that we actually have to sort of jump in with this donated drug to then treat the community. If we're looking at it, we should be looking first at the provision of water, hygiene and sanitation to communities. If we can do that, we will eliminate not just these neglected tropical diseases, but have an impact on hundreds of diseases in Africa, including the biggest killer, which is still childhood diarrhea. And here we are in 2014, still talking about childhood diarrhea.
Thank you, Simon. So let me ask that question then, Ed. Are we going fast enough? Should we be doing more?
Well, I think it's a good question, especially given the progress recently. But given that we've been at this since, I mentioned 1981 was when with some first international conventions, and work obviously started well before that. We should probably be saying clearly not. We're not going fast enough. But I mean, it's clear the speed has picked quite up. We're now in that kind of, I don't know if Simon would agree, but at least at WHO, it feels like we're in that semi-magic zone of getting down to the few hundreds of cases. The certification programs are very followed by ministers and ministries of health. They're driving for it. So clearly the pace has picked up. But I think some of the worries that happen, with guinea worms a little bit different, but with some of these other eradication programs, given the framework for this session, is the question you have to ask of is there a zero-sum game in terms of the work? And Nneka mentioned it vis-a-vis just time, people's time, and the community health workers' time. They're bombarded with different demands from all over. There's a couple of studies that have looked at particularly polio around whether it's strengthened health services and routine immunization or hurt it. And actually the jury's a little bit out, but most of the studies have not shown some conclusive evidence that they haven't. These have been independent studies, and the Independent Monitoring Board for the Global Polio Eradication Initiative says yes, polio is still on track for eradication, and yes, but it also can be reinforcing. But most of the time, the conclusions have been that we've missed lots of opportunities to strengthen the health systems that will be there to deal with all the other problems once we've left. And I think that's a lesson both for guinea worm and for the other programs that we're working on in terms of trying to pick up the pace and to think of that special time when we're after eradication, so we don't find ourselves back in a situation like leprosy.
Yeah, no, that's a very important point for us to bear in mind. Simon, let me ask you the same question. Are we going fast enough? I mean, there's been a lot of things happen recently. I mean, I know in our area of blindness, the DFID, Department for International Development in the UK, has given us an enormous grant to lead a consortium to map trachoma worldwide. But, you're tasked to sort of tackle this, Simon. So are we...
The simple answer is no, we're not going fast enough. We've moved ahead dramatically over the last couple of years. And I think 2014 and 2015 are going to be the absolute critical years to complete the mapping of these diseases. Trachoma will be mapped globally by March next year. There are various other grants looking at the mapping of other neglected tropical diseases, particularly in Africa, where it's always Africa, I'm afraid, where we do have the immense mapping need and also the need to scale up quickly. Resources are being put into neglected tropical diseases, for instance, from DFID, USAID, the Queen Elizabeth Diamond Jubilee Trust, are putting resources into neglected tropical diseases, which is very encouraging. But, and there's always a but, isn't there? I think it's a terrible word, but. I should say and not but. the problem is we need to scale up that mass drug administration to reach all of the communities. And if we as an international community are going to meet the WHO roadmap for elimination and eradication of neglected tropical diseases by the year 2020, we need to be treating an extra 5 million people a month over the next 24 months just to reach those targets in Africa and Asia to reach elimination. So things are getting much better. Resources are being applied to neglected tropical diseases. They are neglected also in terms of funding. Only about 0.6 or perhaps 0.8% of global funding for health goes to neglected tropical diseases. This group of diseases that is impacting on 1.4 billion people globally. So they are neglected in terms of funding, even with these very large resources. If we don't scale up, and we don't scale up quickly, then we will not meet elimination targets.
Yeah, you can see in this context, Ingrid, why we're all very pleased to see your film.
We clearly have to make another series.
Pushing on even though you're a neutral observer and reflecting the world, it is extremely helpful for the advocacy that we're talking about here. What I'm going to do now is just in the last 5 minutes is ask each of the panelists just to take 1 minute for a final takeaway message. And then I'll have one myself at the end. So can I go to you first?
Well, I think I'll start with please watch our films. Yeah. So let me tell you very, very quickly. First of all, if you're obviously at this conference, tomorrow evening at 5:45 in the Amphitheatre Bleu, we are premiering the film Between Life and Death, which is looking at the efforts in Malawi around maternal health and neonatal mortality, where we have worked a lot with IHI, and I hope you can come to that. At the same time, in the evening, the series actually is starting on Al Jazeera English. So it's at 20 GMT, so whatever time zone you live in, 20 GMT for the next 8 Thursday nights. You can see the films, and then you can watch them all on aljazeera.com. And the other thing is to say, I didn't make them. There's a wonderful team of filmmakers based in South Africa who've been around Africa and Asia making them and doing all the digital work.
Well, thank you for that great advert that you've just put in. Neka, what would be a final thought from you?
Yeah, I think 2 points. The one, obviously, which we've highlighted through this discussion is the fact that you have to have a systems-based approach and recognize you may have to make incremental changes to your system to ensure the aims that you focus on. But the second piece that I think we've heard here is there needs to be a harmonization, especially for those of us who are here today. We need to think deliberately and intentionally about how we harmonize our agendas so we're reducing this burden that we're causing to the healthcare systems in which we work.
Yeah, very important point. Ed, please.
Well, just 2 points to echo Neka's point about health systems. I think that what came through in the discussion quite a bit is that what is needed at its basic is sort of a more integrated approach that focuses on communities and people themselves and empowers them to be involved in the decision making. It's some of the same themes that were echoed earlier this morning in Maureen's talk, but this is obviously applied in a very particular case. But having lived in Mali for many years in a small town in the north of Mali, you are dealing with realities there, which Simon mentions, issues of poverty and lack of awareness. But there's also these issues which we didn't touch on so much around instability, political instability, which with eradication efforts really pushes things backwards. It pushes all things backwards frequently when it's violent, but it can really push back eradication efforts. And I think that unpredictability is something that you can only surmount by creating more resilient health systems and taking that type of approach. So I think that that would be the future for WHO. It's why we feature NTDs in this WHO strategy on integrated people-centered care. It's why it was the neglected tropical diseases were the feature of this week's the World Health Day. Featured this. Didn't mention that too, but I'm glad I got that tick in case my DG is listening somewhere. But But I think that returning to the health systems basics of this will be where we'll end up having the biggest impact.
Great, thank you. And then Simon.
Well, apart from bringing back memories of what guinea worm is like as a disease, I think the key message that we must have in mind is the urgent need to scale up mass drug administration, the urgent need to set up post-treatment surveillance, so that when we actually have eliminated the disease, that the health system is able to monitor any return of that disease and address it quickly, so we don't lose the sort of benefits of that. There is a funding gap. There's a funding gap for all of this, and it always does come down to money. The funding gap to achieve full mass drug administration in Africa is only about $300 million. And we've got the drugs, we know the systems, we've got we know what needs to happen to achieve elimination. And we have the communities on side and all of the community volunteers that are undertaking this job. And we also actually have some successes. We've got the guinea worm success. We've got Ghana that is going to eliminate blinding trachoma. That should be certified next year. Ghana as well. And we've got a whole number of projects that are reaching the elimination stage of river blindness. So we know it can be done, and we have the evidence that shows that.
Thank you very much. And my final thought is that I'm left with is, you talked earlier, Simon, about these being community-based diseases. We also, in our countries and our richer countries, which is where I'm assuming most people in this audience have come from, have our own community-based problems and conditions and diseases, whether they're obesity or hypertension or diabetes or asthma. And some of the methods and methodologies here seem to me to be entirely appropriate for working with communities as well. So on that note, can I thank the panel very much on your behalf? Not only, and as a chair, I mean, it's wonderful that you not only have talked sense, but you've kept to time. So I'm really very grateful indeed. So thank you very much indeed.